I have a headache.
It might be a tumor.
It's not a tumor. It's not a tumor at all.
Hi, everybody. Welcome back to Pimp My Pod number 7. And as Arnold told us, we're going to be talking about tumors, specifically soft tissue tumors today. So it is a tumor. Okay, so let's just start with a really quick pick of the week. I'm not going to take a huge amount of time to do this podcast because you guys are so super busy. There's so much material packed in these next 2 weeks, and we don't want to spend too much time with you listening to this. So, pick of the week is a book that I have read by Simon Sinek. You've probably heard of him, mentioned him previously. He wrote this very interesting book called Leaders Eat Last. And this book is really about leadership, and he talks about the military and large and small organizations and how they are successful or how they fail when they don't do things the right way. So if you have any interest in leadership of some sort, which most of you will have some part of that in your practice, then I would definitely suggest taking a look at this book. Okay, let's go straight into some illustrative cases. I'm going to cover 3 cases and kind of discuss various concepts about taking care of patients who have soft tissue tumors. So we'll talk about the physical exam, the imaging. I'll give you some information about the particular patients that we saw, and then how they're taken care of as well. So here's our first case. So this is a 56-year-old gentleman who presented to our office with really complaining about the soft tissue mass on the lateral side of the 5th metatarsal head. That small lesion on the tip of his hallux was really just accessory kind of finding. And if you take a look at both of these, though, you can see that each tumor sort of has its own pretty much physical characteristics. So as with anything, I'm going to obtain a history. I'm going to ask questions about to try to tease out the growth rate, pain associated with it, any history of ulcers, any history of prior soft tissue masses, any prior treatment. I will always ask the patient if they have neurological complaints, so burning or tingling sensations. If I'm going to take out a tumor, I do have to make sure that neurological structures are not damaged, or perhaps even the neurological structure is part of the lesion, and if that needs to go, then the patient may end up with numbness or some amount of disability afterwards, and that has to be considered prior to doing anything. Patient's history, of course, is important. Age will kind of give you an indication of certain types of lesions. Remember that in the foot, the kind of most common non-cancerous soft tissue masses are going to be things like lipomas, fibromas, ganglion cysts. Those are the most common ones. And then, of course, the most common malignant soft tissue mass of the foot is the synovial sarcoma. And we have to be careful because sometimes these lesions can mimic others. So it is very possible, and it actually has happened before, that patients are diagnosed with a ganglion cyst. They go for years before anybody tries to investigate what it really is. And it turns out, and this has really happened to someone in the past, that the patient had a synovial sarcoma. And that can become a real major issue if you miss that diagnosis. So then comes the physical exam after you obtain your proper history. And as you can see, both of these lesions have somewhat different characteristics. The one on the left image is a very well circumscribed, well demarcated, uniform color lesion that is, if you palpate it, it's kind of a rubbery feel. very tight and stiff, and that's compared to the one on the right, where, as you can see, it kind of blends out more. It is, when you palpate it, I can tell you that it was much softer. It was sort of like a mushy rice, kind of like if you had rice in a bag, it would feel sort of like that. So, both of these have different potential causes. The characteristics of these will help give you information. And both of these are most likely benign. So the one at the tip of the toe is most likely a dermatofibroma. And the one on the, the dermatofibroma is the one on the image on the left. And the other one, we're not totally sure what that one is yet. We know that it is relatively well circumscribed, although it is harder to find the borders of that one in comparison to the other one. So remember that a benign lesion is going to be much better demarcated. It will have a more clear margin, and in some cases, if it has fluid in it, it will transilluminate. So if you were to put a flashlight on the lesion, you will see light go through the lesion, whereas if it's solid, it will not. Now, also, in some cases, you could actually have a fluid-filled lesion, like a ganglion, and it's so tight that it feels like a solid mass, and that can sometimes be a little bit tricky. Okay, so we obtained radiographs in the office, and you can see that we have these two radiographic views of a partial DP and a lateral radiograph of this foot, principally in weight bearing, and you can see that there is simply increased soft tissue density and volume on the lateral fifth metatarsal phalangeal joint area. You can see that it sort of blends out into the other tissue as opposed to being very well demarcated. There do not seem to appear to be any other heterogeneous findings, so there's no lytic lesions inside of it, and there's no bone involvement. It's possible that you could see bone involvement if the lesion is pressing up against the bone. It can actually erode the bone. Now, just as a aside, this patient also has moderate stage hallux rigidus, and you can see the osteophyte formation on the lateral side of the first metatarsal phalangeal joint. Those are really asymptomatic at this point, so just to point that out. Okay, so in order to find out more, we could have biopsied it in the office, which we actually did, and prior to obtaining this MRI image, we had attempted to aspirate something out of this, and nothing came out. So we think that means that it's a solid tumor, and my next step is to order an MRI. And if we're going to talk about imaging methods, you could see that the X-ray did not show you the same anatomical detail, the same information that you can get from the MRI. So from an imaging modality, MRI is 100% the best imaging modality we have, for the reasons I mentioned. The radiographs help us to determine if there's any bony involvement, but it really doesn't give us as much information. Now, if we really need to know exactly what this is, then of course biopsy is our single gold standard. So now, looking at this MRI that we obtained, I ordered an MRI of the foot. I ordered this without contrast. So you can see that I'm showing you the same views of a T1 radiograph on the T1 weighted MRI in a transverse view on the left image, and a T2 image, the same one, on the right side. And you can see that this is a very homogeneous, well demarcated, well circumscribed lesion that doesn't appear to be involving any of the rest of the foot. There's it's one lesion. It's not loculated. It perhaps might be pushing the fifth digit or the fifth proximal phalanx medially, because it looks like that joint might be slightly sublux, but hard to tell with that, because fifth digit's going to oftentimes have hammer toe deformities independent of that, but it may be. Don't get confused if you don't see his digits, though. Remember that these are slices. These are 5 millimeter slices, and we don't see the rest of the foot. So now then, if we look at the T2 image on the right, you can see the same lesion, but it has fluid in it. So this image is enhancing fluid because it's a T2. And you can see that there is some bone marrow edema in the fifth metatarsal, but there's no erosion. So that bone marrow edema is very nonspecific. I would tell you that that is not an infection. There's no osteomyelitis. There's really no involvement of that bone other than the fact that this is an inflammatory process here, and that's why the bone has some increased signal intensity. Then when we look at the mass itself, you can see that it's very similar in shape to the T1 image. It's well demarcated. This clearly has fluid in it. So I would be thinking that this is probably a ganglion cyst, would be my first thought of this. But even if you're not sure what the diagnosis is, you can tell that this is probably a benign lesion and not malignant because of its being well demarcated, having a very clean margin, being very homogeneous in appearance, and not extending out into the rest of the foot. Okay, so let's move on to case number 2, and this comes from one of my former residents, Dr. Ishin Mustafa, who had a patient that she saw, and there is this lesion on the plantar surface of the foot. It may be a little bit hard to see here, but basically this presents as a painful enlarging mass kind of under the third metatarsal and the part of the second, kind of maybe extending laterally onto the fourth a little bit. And it's a little difficult to see here, but it kind of bulges outward. So, of course, the same physical exam occurs, the same history, really trying to give you some insight as to what this is beforehand. She had tried aspirating this, and it did not aspirate any fluid at all. She thought perhaps, her differential diagnosis for this included, a ganglion cyst. It included a Morton's neuroma, although if it were a Morton's neuroma, this would be an incredibly large one. The fact that it's centered under the second intermetatarsal space would make it also a little bit more unusual for a neuroma. Maybe it could have been a schwannoma or something along those lines. This patient's complaint was non-neuritic, so not burning and tingling, no heat sensations, and you can also see that it is not pushing the digits apart, that classic Sullivan sign that you guys would have learned in your prior PMP2 class, which is pushing the digits aside because of the enlargement of the nerve itself. Okay, so then she obtained this MRI, and I will run the video so you can see it. Let's start with this axial view on the left. Then I will pause it when we hit the spot. So there's your markings for what the size. Let's do that one more time. Okay, and I'm gonna attempt to pause it when we get to the spot where the lesion is. Okay, now you can see through the writing that this is a somewhat heterogeneous but very well demarcated, well encapsulated lesion underneath the third digit, extending from the midfoot. Extending on the forefoot underneath the metatarsal head areas, And now let's take a look at this one. You can even see the lesion right there on this T1 weighted image of the transverse view here. And as we look at it, you can kind of see its extent. And remember, each one of these is 5 millimeter slices. So you can, if you went from one slice to the next, you can see that you can kind of measure the size of this. And remember, you'd want to see this in more than one plane. So this is why I'm showing you two orthogonal or 90-degree views to each other, so you get a chance to appreciate the overall size of this. So again, there's some of this. This is the most plantar aspect of it. Well demarcated, somewhat irregular in shape, and maybe a little heterogeneous, but mostly homogeneous. Okay, remember, you always have to know where you are when you're looking at this, right? So you can see that we have the 5th and 4th metatarsal heads, and then this lesion is in the same plane as these. So this is a very plantar view of this. Okay, so this, again, doesn't tell you exactly what it is, but it does, it does give us a good delineation so we understand where to go from here. Okay, so she then did surgery on this patient, and this kind of shows the choice of incisions. Now, in your lectures, Dr. Wan mentioned that most of the incisions on the foot are linear or longitudinal on the foot, and that's actually very important. We don't want to damage neurovascular structures, but the other thing to keep in mind is that the foot is made in compartments, and most of those compartments are longitudinal kinds of things. So they're kind of running in that longitudinal direction, and if you have to say amputate a part of the foot, then you can sometimes you're able to remove a part of the foot within a anatomical compartment. Like each of the metatarsals is separated by a tissue wall, and that tissue wall in some cases can help prevent the spread of a cancerous tumor to the another part of the body, prevent metastasis from happening. Now, in this case, with this particular patient, a plantar incision runs parallel with the relaxed skin tension lines, and that means that the incision will heal smaller or thinner, so perhaps it would be a little less of an issue. This is most likely benign, so Dr. Mustafa did not feel that she needed to go longitudinally. The other aspect about this is relates to a concept that Dr. Wan mentioned in his lectures, and one of that concept was about making the incision large enough, just large enough to be able to remove the mass. So not too small, so you're not fighting the incision, and not too large, so that you're not damaging more structures or potentially seeding other areas. So this lesion runs mostly in a medial lateral direction, and if she made a longitudinal incision here, it would actually have made it harder for her to actually get at all of the lesion. So she made this, kind of frown type incision, and then was able to take things out. So here's her dissection, removing the mass. You can see a lot of fatty tissue on the plantar aspect of the foot. Again, that's normal. And there she's starting to get at the lesion itself. And as she described this to me, the lesion was very firm. Had a kind of was very well encapsulated, came out as one piece, and had this sort of fatty rim around it. So there's the lesion, and you can see that it measures, just shy of 2 centimeters in size. You generally measure these, length, width, and depth to get a 3-dimensional volume, and you can see this yellow, kind of color to it. that yellow is actually a little darker than what you'd expect for a normal fat pad in the foot. This was a fibroma. Ironically, she thought it might have been a neuroma. They were thinking maybe it was some other kind of lesion. But when she sent this to the pathologist, it was a fibroma. It's yellow because of the fat overlying it. Um, so one thing to remember is that the first real specialist that you're going to enlist in your assistance, in your help, is going to be the pathologist. And you could decide to either perform a what's called a frozen section, where you'll remove either a part or all of the lesion and send that lesion down to the pathologist, and the pathologist will cut it up quickly, look at it under a microscope, and then tell you if it is benign or cancerous, and if it extends to the margins of the lesion. So we usually want to remove lesions with a cuff of normal appearing tissue, and then that will allow the pathologist to determine if it is well located and not extending past that cuff of normal tissue. So a frozen section requires some planning. You have to discuss this with the pathologist beforehand so that they're aware that it's coming. You literally sit and wait for a couple minutes and while the pathologist is doing their work, in order for them to give you a report back. If they tell you that there is still tissue in there, then you remove that tissue and send that down to the pathologist as well. So pathologist is going to be your first specialist that you enlist in the group of assistants with this. Okay, so here's the third case to finish up today. This is a case of mine from a few years ago. This was a 24-year-old Caucasian female who presented to me as a new patient approximately a month after she sustained a motor vehicle accident. And according to her, she noted that she had increased mass on the lateral side of her ankle that was uncomfortable for her, and she initially attributed this to the motor vehicle accident, that she was hit, and somehow this caused her problem. Now, I can tell you that I cannot tell you one way or the other whether or not the motor vehicle accident actually caused her mass, but highly unlikely. So we got her history. She did not have any burning pains. Remember that tumors will often will often enlarge kind of away or centripetally, I guess. So whether they're benign or malignant will change the way that they enlarge. I included her physical exam here to kind of give you a feel for how this might be described. And you'll notice, and this is going to be true for all of the charting that you do, that her vascular, neuro, and dermatologic lesion descriptions are pretty small, right? So only the pertinents are here. She's got palpable pulses. There's no Tinel's, so I'm not concerned that this lesion is rubbing up against her sural nerve or her superficial perineal nerve. The dermatological, really what matters is that she has no open lesions. And then we included the mass in her musculoskeletal, and you see that because the musculoskeletal system is the one that we've chosen to incorporate this into, it is the largest section, and that should be true for anything. If you have a dermatological lesion, then your derm section should be largest. If it's a neuro lesion, your neuro section should be largest. So keep that in mind. And if you look at this, you can kind of see the way that we described this. This was a firm, compressible, non-fluctuant, rubbery. We using all these words to describe this kind of round lesion. We are mentioning that we don't see other masses. She's painless. The POP is pain on palpation. She does not have any pain to the perineals, so we know that her perineals really aren't involved. Okay, so if you want to read that further, go ahead and hit pause, and then you can keep going as we need to. Okay, so her radiographs were negative. It didn't show anything of significance. And here are 3 characteristic images, MRI images, and my question to you would be: is this a T1 or a T2? This is a T1 image, and you can see that the bone is white, which means that we're suppressing fluid. And we're looking at from left to right. We're looking at an axial view, then a sagittal view, and then a coronal view from left to right. And if you look at this, you might want to hit pause to take a look, because there are actually multiple masses in different areas. So look carefully. First, get your sort of visual, spatial, geographic location. Figure out where you are. So on that axial view, the left one, you can see that the Achilles is at the bottom of the image, and the anterior part of the foot is on the top of the image. Medial is going to be on the left side of the image, and lateral is on the right side. So when you look at this, you can see that there are multiple homogeneous, what appear to be well circumscribed lesions, both on the medial and lateral, as well as posterior aspect of the ankle joint, including the subtalar joint. So I'm going to point out some lesions. You can see there's one here. That's the large one that we can see clinically. But then across from it, there is one here. And then when we look over on the sagittal image, you can see a posterior one. This is pretty much in Kager's triangle. There's another one here. There's questionable amount of material that is now very difficult to say that it's well circumscribed, and it seems to proceed into the posterior facet of the subtalar joint, and also in the anterior aspect. And then when we look over on the coronal view, you could see there's the lateral again. We can see where it's bulging out, and then there again is another one. So this is what we ended up. We took this patient to surgery, and we made a medial and lateral incision, and you can see the characteristic lateral incision here. And what I can tell you is that this was a small surprise, not terribly. We did not think this was cancerous, and we had a pretty good idea as to what this was before we went in, because that MRI view is actually characteristic. The image quality is actually characteristic of a particular lesion, which I'll tell you what the diagnosis is in a minute if you can't figure it out. So you can see that the mass is somewhat brownish to grayish in color. That means that it has melanin pigmentation in it, or hemosiderin pigmentation, not really melanin. It has hemosiderin pigmentation in it. And this extended across the ankle joint, across the subtalar joint, on both sides. As we were removing it, some of it came out as firm, well demarcated material that was encapsulated and easy to come out. But really, most of it was actually the characteristic was more of like snot, I guess, like kind of somewhat liquidy, very difficult to take out. We had to actually pull out little pieces of it as we went. Very difficult to get it all out. In fact, we probably did not get it all out. So this was sent to pathology, and the diagnosis came out with pigmented villonodular synovitis, PVNS. So we did not send this for frozen section because we felt that we had a pretty good idea, because that MRI, those images are characteristic of PVNS. Now, there are, as Dr. Wan mentioned in his lectures, there are adjunctive treatments that are oftentimes available for these. Now, whether they're malignant or benign, obviously the adjunctive treatments will differ, but in this particular case, the adjunctive treatments for this depend on whether or not this is considered a nodular PVNS or a diffuse PVNS. And this patient actually had a diffuse PVNS, which makes her prognosis for recurrence lower. So, meaning that she has a greater chance of having a recurrence. So, one of the adjunctive treatments, as an example for just this particular patient, is radiotherapy. So basically, X-ray radiation could be a method. This patient decided against that after I counseled her, and she just wanted to kind of go with the, go with her surgical treatment, as she actually resolved this with no problems. I did not, unfortunately, follow this patient out more than a year. She had been fine up until that point, but who knows? Maybe it would have come back, and maybe somebody else had to take care of it too. I'm not sure. Okay, so final conclusions here. I would like to talk to you just really quickly about difficult conversations. As a physician, you're going to have some conversations that are not comfortable for you or for your patients, and I want to give you some advice on how to handle those things. In the past week, I have had a conversation that included telling a patient that she needed to have a transmetatarsal amputation. She was not happy about that. And I had to tell her, I had another discussion with a patient's daughter who had suffered a complication from another physician and wanted to sue the physician. And I did not feel like it was going to be in the patient's best interest to do that, so we had this discussion. So the first thing I'll tell you is I feel that the golden rule is the most important thing when discussing these with patients. You have to think about what you would want as a patient if you're going to need an amputation, or if you have cancer, or if you're unhappy about care. How would you want to be treated? Would you want an honest physician who's going to tell you how it is, whether you are terribly happy with that result or not, or if they're going to lie to you? So, as difficult as it is, you try to be as honest as you can. So that's the first thing. The second thing is you need to give these difficult conversations time. It destroyed my clinic to have the conversation with the patient's daughter about the lawsuit issue, because I gave her about 20 extra minutes of time, and I had a bunch of other patients waiting. Now, what I could have done was ask the patient to come back and have the discussion with me later, but what I have found is if you tend to do that, the patients will simply not come back. They have a moment where they feel like they need to get something off their chest, and as difficult as it is, you just have to do it right then. I apologize to my other patients for being late, because I never like to be late, and I'm usually on time, so my patients understood that. Then we had an honest discussion, and I listened carefully to what the patient says. I try to incorporate the patient into the discussion as much as possible. I try to understand the situation as much as I can, and then I am cautious about the kind of advice I'm going to give, especially if it's a very sensitive kind of issue. So I always recommend that my patients speak to their doctor if I'm giving a second opinion and someone is unhappy with the care they've gotten. I usually try to refer them back to their original doctor for them to have that discussion. So, um, you know, you're going to have these conversations. I think if you give your patient time, you treat them with absolute respect, you listen carefully, and then you give your best, honest impression of the situation, I think you'll do great with these very difficult conversations. So, on that, I thank you very much for listening. Please feel free to let me know if you have any questions, and good luck in class.